So today I'd like to talk about the natural history and conservative treatment of frozen shoulder. So what is frozen shoulder? The medical term is adhesive, so stuck, and capsulitis, which literally means inflammation of the capsule. I like this quote from the AOA, or a position statement, saying it's a condition of unknown etiology characterised by both active and passive loss of motion in the absence of a known cause. As Jones pointed out, it's common. Occurs mainly in women in the fifth decade. One of my Chinese patients reliably told me that over there it's known as 50 shoulder. It's not uncommon for this to be bilateral, although luckily enough that seems to happen at a later date, very uncommonly at the same time. Another one of my favourite medical words, idiopathic, nice fancy way of saying we really don't know what causes it. We know there's a clear hormonal link, particularly with diabetes, thyroid disorder, and also dyslipidemic syndromes. People in the past have postulated an autoimmune cause, although there's never been a clear definition with a serological marker. It may occur as a post-traumatic phenomenon, post-operative, particularly if there's a mobilisation of the shoulder. And also, don't forget, neurological problems, and Parkinson's is the one that is most commonly associated. So what happens in frozen shoulder? Probably almost the most important point in this whole talk is that it gets better. So the natural history is favourable, and that's the first thing I tell everyone that I see with a frozen shoulder. We know that it runs through 3 phases, so we talk about a freezing, frozen and thawed out, and you can see the time frames that may occur. But overall, it can take quite a while for it to get away, sometimes even up to 2 to 3 years. So improvement is generally expected, but if you look at some long-term studies to follow up, quite a large proportion of people may have some mild residual loss of motion, and a lesser percentage may actually have some clinically relevant loss of motion. So we do feel that effective treatment of frozen shoulder in the early stages will shorten the duration of symptoms and also disability. So what are those non-operative treatments? As a good doctor, I like to go back to education and reassurance. Really just sitting down with the patients and saying, look, this is a frozen shoulder, because a lot of times the diagnosis has been unclear, and then telling them, look, it's going to be painful and it's going to be stiff, but it will get better. That's very reassuring to patients. I have a lot of Mediterranean patients at Hurstville as well, and they all think they have cancer until proven otherwise. So telling them they don't have cancer, they're sometimes very happy with that. Empathy is important. The pain in capsulitis can be quite severe. And really, the patients don't sleep that often. The night pain's quite an important symptom of frozen shoulder. So each time I see one of Tim Neville's slightly neurotic ladies in their 50s from the inner west, I do take a deep breath and think about both of these points. What treatments do we have medically? Obviously, analgesics are important. That may be as simple as regular paracetamol with the addition of codeine. Anti-inflammatories are helpful in some patients to reduce the inflammatory process. And there can be a role for oral prednisone. It has been studied. Cochrane did a review of this in 2006 and showed silver level evidence for improvement in pain, function and range of movement over the first 6 weeks. We do know there are significant side effects from using long-term steroids, and also catastrophic short-time sort of one-off effects such as AVN in the hip. So we're a little bit judicious with the use of oral prednisone, but it can be helpful. I'm certainly not going to stand up here and tell you all how to suck eggs with physiotherapy treatment, other than to say physiotherapy is a very important part of treatment for frozen shoulder. Although there's a couple of points I made based on 2 Cochrane reviews that came out just recently. One was looking at electrotherapy. A lot of modalities were looked at and most showed no improvement, although there was some very low-level evidence for laser. The other one was that given that physio is so commonly prescribed for frozen shoulder, it's interesting to note there's never actually been a clinical trial to show that manual therapy or exercise is any better than doing nothing at all. What has been proven is that in one very good study by Corrette, where they looked at intra-articular cortisone injection versus physio alone, is that at 6 weeks it was not as effective as cortisone injection. But the other point from that paper, and they had 4 arms, there was cortisone and home program cortisone plus physio and then placebo plus home program and placebo plus physio is that the results of steroid plus physio were much better than any of the other groups. Obviously work within the patient's pain. I will see patients who come in and sometimes if the physio is a bit too aggressive, it does make their pain worse. It's an irritable condition, so you need to make sure that you're not pushing them too hard. And I guess making the right diagnosis maybe helps with that, so you're less inclined to push them if you know that it's an adhesive capsulitis. There's no secret with the manual and the physical treatment for this. We try to achieve active and passive range of movement. I always like to get a picture of Bestie in his turtleneck sweater somewhere in the talk. And strengthening for the scapular stabilisers and the rotator cuff is also important. As a sports physician, medical practitioner, one of the other treatments available to us is intra-articular steroid injection with or without the addition of a hydrodilatation using saline. We've been doing intra-articular cortisone injections for frozen shoulders since the mid-60s. It has been studied widely and there are a number of papers to show levels of improvement in both pain and function, especially within the first 6 weeks. And I've previously mentioned Corette's study where he actually demonstrated that cortisone plus physio seems to get a better result with regards especially to range of movement and function. Buckbinder did a very good paper in 2004 looking at intra-articular steroid plus saline hydrodilatation as opposed to placebo and showed improvement in pain, range of movement and function at both 3 and 6 weeks. The one question that's widely asked in the literature is whether there is any benefit to the addition of a hydrodistension as opposed to simply doing an intra-articular cortisone injection. This is a little bit controversial. There's not a lot of high quality papers looking. This is probably 5 that were reviewed in Cochrane's collaboration back in 2008. What they summarise from this, and mainly based on one very high level evidence paper, as opposed to 3 low level evidence papers, that there was silver level evidence for intra-articular steroid injection and hydrodilatation. There's improvement in pain at 3 weeks and improvement in disability at 3, 6 and 12 weeks. They didn't feel the evidence was strong enough to suggest that it was categorically better than steroid injection alone. So what's my preferred practice for this? I will preface this by saying I love seeing frozen shoulder patients. They're really cranky, they've got a lot of pain, they don't sleep, and I have a treatment that I believe helps the majority of them. I do perform ultrasound-guided cortisone injection and saline hydrodilatation. My preferred injection, and we can maybe have a little debate at the panel discussion about what the best volumes are, because there's certainly no hard or fast rules there, is I like to use 2 mils of Celestone, 5 mils of local anaesthetic and 20 mils of normal saline. It's injected under ultrasound guidance into the posterior shoulder in a lateral position as seen on the screen. And this is just a picture of my needle, which is just here, going into the shoulder joint at the region of the posterior labrum. Most patients tolerate the procedure very well. I'll always examine them afterwards just to see that their pain has improved and their range of movement has improved, and both of these things usually occur almost straight away. What are the side effects of this procedure? Absolutely the most important one is infection. It's uncommon. Knock on wood, it's never happened to me yet. But if it does happen, it's a disaster. So you need to practice very good aseptic technique. They may have some post-injection pain for a few days, which is normal, and there are issues with steroids, such as getting a flush or not sleeping that night, which are minor things that settle within a couple of days. If you do inject a diabetic, you need to warn them about their blood sugar because it will go up. Got Bestie back in the turtleneck. Post-injection treatment, I get them doing a range of movement programs straight away, which involves flexion and rotation, doing some wall walking, using a pulley, and also doing some passive internal and external rotation. They perform the exercises 2 to 3 times daily. Based on Corette's study, I get physiotherapy in every patient, usually at a week once the injection's working and their post-injection pain has settled down. I review the patients at 4-week intervals. and I will generally repeat their injection up to 3 or even 4 times until they reach resolution. My thanks to John for this study, an observational study he did a few years ago, looking at outcomes, outcomes from frozen shoulder and hydrodilation. The numbers are good, 300 patients. Demographics are what we'd expect, mainly female, mainly in their mid-50s. And what he's shown there is that 3/4 of the patient had a good or excellent result. 15% have a repeat injection. My figures are probably higher than that. A lot of patients come back actually requesting another injection because of the pain relief they've had. A significant reduction in medication use, which reflects an improvement in their pain. So not a sort of a high quality scientific study, but I think a nice look at a large cohort of patients to see how they have progressed after this procedure. So what are my take-home messages about frozen shoulder? Probably the key, and Jerome's talk went through it beautifully, is make the diagnosis. Everyone, you've got to examine passive external rotation because that's probably the single most effective test at picking up the stiff shoulder. Education, tell the patient it is self-limiting, they've got pain, it will pass, the shoulder will get back to normal. Medication, physiotherapy, trying to maintain their function within pain limits, and consider the early use of either intra-articular steroid with the addition of a saline hydrodilation. Thank you.